righty. So many times you may have heard us say, we're going to talk about your case at Tumor Board. Tumor Board is a terrible name for our multidisciplinary conference, much nicer name, that we have twice a month, where the melanoma team, and that's everybody from medical oncology, surgical oncology, radiation, radiology, clinical trials, pharmacy, dermatopathology, we all come together on Zoom and we talk about new patients, challenging patients, anybody that is brought to the agenda. So we thought we would do a case study here based on a real patient situation. I've invited 3 of our excellent providers to come help out. So if excellent providers could come up, Dr. Hanks, Dr. Alrohill, and Dr. Doherty. Usually there are sometimes 12, 15, 20 people on the conference call, but today we have 3. All right. And if each of you can introduce yourself and tell us what you do here at UNC. Dr. Hanks?
I guess I'll start. My name is Brent Hanks. I'm a medical oncologist, physician scientist.
My name is Kristen Doherty. I'm a surgical oncology fellow.
I'm Rami Rohil. I'm a dermatopathologist here at UNC.
Okay. So again, this is based on a true story. The identity has been switched around a little bit. So GM is a 51-year-old male who lives in the Triangle with his partner and is a software engineer. He's had this mole on the right side of his neck for most of his life. And then in the fall of 2023, he nicked it while shaving, and it started to ooze and grow. So a full year later, in 2024, he presented to a UNC head and neck surgeon, and that's just the way the you can't hear me, I'm so sorry. Okay. Is that better? Okay, sorry about that. Trying to be Phil Donahue for anybody who knows Phil Donahue, but I'm dating myself. So the referral came to a UNC head and neck surgeon after a biopsy was done by his local dermatologist. And for most of our new patients, those slides that are done by the local dermatologist come to us at UNC, and Dr. Alrohill and Dr. Medema review them as well for another pair of eyes. Okay, the pathology. So as Dr. Ferris went over, the Breslow depth was at least 8.5 millimeters. It was ulcerated. It had a very high mitotic rate of 21. It was a T4B, so pretty deep, and that B came from its being ulcerated. And it had this BRAF mutation, which Dr. Colicchio mentioned is a mutation on the melanoma that he did not inherit, nor would he pass on to any children. But it can be a factor in future treatments. We will look at the slides in a moment, but traditionally, Dr. Hanks, would you then send this slide off, this specimen off for genomic testing with a company like Tempus or Foundation One?
So being new at UNC, I can tell you that my practice before was that I would not necessarily send it off.
Okay.
And that we would actually get targeted genetic studies for BRAF mutations, as well as some of the more common mutations. But if you order one of these testing options, that's certainly one way to go. You're just going to get a much broader array of genetic targets.
Okay. All righty. Dr. Alrohill, can you show us the slides?
Sure.
And Trish, I don't know if you're going to, because we're going to have to exit this and bring up yours.
Nope. It's neither.
Yeah, we did send them in. You did not bring a flash?
Nope.
Okay. All righty. bear with us for a moment. Technology is great till it doesn't work, so. We did send them to.
Is this you, melanoma? Let's try this. Patient day. Let's close this and let's try reopening this.
So it should be titled 4-7 case pathology images.
What time is it supposed to be? What time is it now? It's 3:03. This is 1500. Is this not it? No?
So it should look like this, and the title should be this.
Do you have a way to send that?
Yeah.
Okay, here, let me. Scan that and then send it to that. Or drop it into there.
Drop it.
Yeah, go into a Dropbox and then we'll just pick it up from here. Let me just take that file and drop it in.
Oh gosh, is that gonna work?
You just send it to Beckett.
You could do that too.
What's the email?
Sorry, it's conference tech here. Sometimes it takes longer though.
Let me try to download it and also upload it. Yeah, I should have. It was on. But
Yeah,
I
I mean,
assumed that it was.
I assumed as well, so.
Did it both ways.
I apologize. We thought we had everything set up, but clearly, yeah, we were doing so well.
Well, the one thing I can, like, it's rare for a dermatopathologist to show his face to patients, and for patients to even know what a dermatopathologist do. So just to introduce myself, I'm Rami, I'm a dermatopathologist here at UNC. What we mainly do, our role is, if anyone takes a biopsy from you, or an excision, or a sample, or a needle core biopsy, that tissue, we look at it under the microscope in order for us to define what kind of tumors is happening in the skin. My specialty is dermatopathology, so it's skin specifically skin. So we assess the tumor, what type of cell it is. We assess the prognosis of the disease. So when we say the depth of the melanoma, we measure it microscopically. It's not eyeballing, it's not a ruler. It's more of a microscopic measurement to tell what is the depth of the melanoma, and that's how we can decide is it T1, T2, T3, T4. Ulcers, sometimes like the ulcer is very obvious clinically, but they're microscopic ulcers that we only see under the microscope. So that's another thing that we assess microscopically to tell you, the patient, what is the pathologic stage of your disease. Other things we assess is lymph node status. When we get lymph nodes, so we detect the metastasis if it's clinically occult, where it's not felt, but it's micromillimeters, and we measure it and we're able to see it under the microscope. So that's mainly our role in what we do in dermatopathology, to assess to allow for your surgical oncologist and your oncologist to later on decide what type of treatment and therapy for you to undergo. Great. So this is the shave biopsy. That's how it looks on low power. So when the tissue is taken, we look at it at the bench, and after that, the tissue is processed so we can put it on a slide. And when it's placed on a slide, it's usually looking pink like that. That's how it looks like. And believe it or not, that's what we read. These are mainly how they look like to us. So we can see a big nodular lesion, like we see this almost mushroom-like growth on top over here. And here the background shows you the normal skin being present. So this is the measurement of how we measure the thickness of this tumor. So this one is, it's a very thick lesion. So the highest thickness is 4 millimeter. Most melanomas that I diagnose in my practice that come mainly from dermatology clinics are usually less than 1 millimeter. So higher than 4 is rare, but it does happen. And usually the thicker it is, the worse it is. For you to visualize what 1 millimeter is, 1 millimeter is basically a dime thickness. So the thickness of a dime is 1 millimeter basically. So this is like 8 dimes stacked on top of eight and a half dimes stacked on top of each other. So it has a lot of thickness to it. On closer inspection, when we look at it, we see this is, on this side, this is the skin surface, which is called the epidermis. So this is what our skin, what you're seeing on your skin surface. This is the epidermis. This is what it looks like microscopically. And on this side, we see it's absent. So this is a definition of ulceration. So we have ulceration that upstages the melanoma. And lastly, this is the tumor on closer inspection. So we can see this nested-like growth. There's like subtle nests and sheets of cells of really atypical cells with mitotic figures. And on close-up images, we see like in the center, what we mean by mitosis is a cell that's undergoing division. Our normal cells, for the most part, like a regular nevus, is silent. It doesn't undergo mitosis, it doesn't regenerate, but melanoma, it's replicating. So that's why we see that even in our eyes microscopically of a cell undergoing division, cell division. So these are parameters that we record. So that's how we were able to reach thickness of 8.5 with ulceration, with multiple mitotic figures, and that's how it translates into PT4B, the pathologic stage T4B melanoma in this case. That's it. Great, thank you.
Trish, SOS. Yeah, you're my tech guru.
Oh. Okay.
Thank you.
See if I might have to get him because I'm not.
To get back to
All right.
mine.
Paul's gonna talk.
I'm going to talk. We're trying to get back to my slides. That's why I didn't go into STEM. Okay. It did work beautifully. It's been jinxed today, so.
That's pretty much standard meeting protocol. It worked last night.
Yep,
So I have a naive question.
of course.
Had the patient not mixed the mold, would it have not, I mean, was
Yeah.
it melanoma?
What time was it for?
We're discussing your case. Yeah, I mean, that's a really great question. You know, it probably would have declared itself soon thereafter. It was probably a good accident. And we do hear that in other wacky ways that things have been discovered. Yep.
I may not be that guy, but I did shave off that mold, so.
Okay. Thank you so much, sir. Okay. So then the ear, nose, and throat provider ordered a CT of the chest, abdomen, pelvis, and neck, looking for metastases. Can you hear me? Yeah. Looking for metastases. The chest CT was normal. The abdominal CT was concerning. It had several, when they say lytic foci, so many of the bones had some lesions in them that looked concerning. And if you've ever read a radiology report, they don't say anything definitive. They can say things like concerning for, worrisome for, suspicious for, because they can't diagnose unless there's a biopsy. And then this gentleman happened to have a large kidney stone in his left kidney, and they also said suspicious for this fancy word that is inflammation of the kidney. And this is a picture of the CT scan in the pelvis, and the provider, the oncologist that took care of this patient, said it was very hard even to appreciate those lesions on a CT scan. So the ENT provider said, we need some help here, and referred this gentleman to see one of our melanoma medical oncologists, and we saw him in November of 24. And we ordered a PET scan and a brain MRI just to get a better picture of the whole body, including the brain. The PET scan is not great for looking inside the brain, so that brain MRI is kind of the gold standard for looking for metastases in the brain. And then on clinical exam, you can see that there were some satellite nodules at the primary site. Thankfully, the brain MRI was normal. His creatinine, which reflects kidney function, was slightly elevated. And there was a finding on the scan of a thyroid nodule, which we did get a fine needle aspirate of it later, and it was benign, it was fine. The PET scan, as I said, showed this right thyroid nodule. And then they said, you know what, we looked at these bony lesions and we can see them, but they're not really lighting up and they're probably too small to appreciate on the PET anyway. So we weren't convinced that that was a bone metastasis that we were looking at there. So melanoma staging can be pretty complicated. They look at tumor depth, lymph node involvement, and metastases. And under that N for lymph node involvement is kind of a subtype of what we call satellites. So you may recall that the clinician saw satellites at the primary site. So the final staging was a T4B, reflecting that worrisome depth with ulceration. These satellites, which made it an N1C, and then no defined proven metastases. So it came out to be a 3C. So the question is, what do we do next? Do we lead with surgery? And Dr. Dougherty, do you want to comment now on what we should do as far as surgery?
So typically in this scenario with the satellite lesions, we would not lead with surgery because we would try to get rid of those and sort of quote unquote downstage the cancer with therapy up front, systemic therapy.
Okay. Dr. Chen from radiation could not stay for this tumor board, but I did ask him to chime in, and he said radiation would not be his upfront modality here. So then we've got a gentleman with a BRAF mutation for which we have pills, but we also know that immunotherapy can give you a more durable response. So, dear Dr. Medical Oncologist, what would you recommend next?
I think really standard of care in these circumstances is start out with some form of immunotherapy up front that we know now. You know, probably over the last few years, probably the biggest advance that we've made from a systemic therapy perspective is our understanding that upfront, or otherwise known as neoadjuvant immunotherapy prior to surgery, can really improve outcomes in the long term. So we really, whenever possible, we try to start these patients out with some form of immunotherapy before surgery.
Okay, and that word, and Dr. Cliccia mentioned it, of treatment before surgery is called neoadjuvant treatment. But then we had another quandary. Do we lead with SWOG 1801, which was pembrolizumab or Keytruda for 3 cycles prior to surgery, versus the NADINA protocol, which is immunotherapy of ipilimumab and nivolumab? What do we do next? I mean, toss up. Dr. Hanks?
Well, I think, you know, truthfully, we don't really have any head-to-head comparison between those two strategies. So there's not necessarily a right or wrong way here. I think when you're looking at combination immunotherapy, which would be the NADINA protocol, you're looking at 2 cycles of ipi-nivo, ipilimumab, nivolumab immunotherapy. While the objective response rate, or the ability to shrink the tumor, is quite high, you're looking at, you know, almost 60%, really 56, 57% response rates. However, the toxicity and the side effects are going to also be much more significant. So we see anywhere between 35 to 40% of patients will develop a higher grade toxicity on that protocol. So that is something to consider. And then we compare that with the SWOG 1801 protocol, which is an anti-PD-1 antibody, in this case pembrolizumab or Keytruda, which is another form of immunotherapy, and that's given 3 doses before surgery. The response rates are modestly lower, but the toxicities are also quite a bit lower. You're looking at 7% grade 3, 4 higher toxicity rates relative to over 30%.
Yeah.
So I think there's, again, there's really no clear answer for a lot of these cases.
Now, you may recall that he had some kidney concerns, some inflammation in the kidney. Would that weigh into your decision?
Yeah, absolutely. I think that would be a very reasonable thing to be concerned about. I think fortunately, the incidence of interstitial nephritis or kidney toxicity on these regimens is actually quite low. You're looking at higher grade toxicities at less than 5% of patients that are treated with these therapies. When you combine it with Yervoy or ipilimumab, it is going to go up a little bit. So I think that's reasonable to consider. And given the unusual read from the radiologist in terms of his kidneys, that would be something to be concerned about.
Okay. And I know for ipi/nivo in stage 4 disease, sometimes we do ipilimumab 3 milligrams per kilo versus 1 milligram per kilo. In this NADINA study, which dosing did they use?
They used the 1 milligram per kilogram dosing, and I think that fortunately we do have a clinical trial that was designed, a European trial that was designed that compares the ipilimumab 1 mg per kg versus ipilimumab 3 mg per kg with nivolumab, and what they found was actually quite similar outcomes from an efficacy standpoint. So the response rates are just a few percentage points lower when you're using the 1 mg per kg dosing. The toxicity rates, and of course that was really the main reason for doing the study, was to understand whether or not we could reduce the toxicity or side effects by lowering the dose of Yervoy. And the dosing was, the side effects incidence was actually significantly less when we went to 1 mg per kg. So I think it would be very reasonable to go 1 mg per kg whenever feasible.
So insurance denied the plan. The physician had actually put in the plan for SWOG because she was concerned about his kidney risks. And so insurance pushed back. They probably said, this is a stage 3 patient. Why are we doing immunotherapy up front? Why aren't we going to surgery? So there was what we call a peer-to-peer, where the physician here speaks to a physician at an insurance company who may not be an oncologist. And it was a very interesting outcome. The gentleman with the insurance company actually pushed for NADINA. And that's what we went with, which is interesting outcome. So he got his first dose of the ipi/nivo on November 26th. And he got 2 cycles, 3 weeks apart, and the cancer site had flattened markedly, so it was looking really impressive. And then, of course, right before Christmas, he sent me a MyChart message that he had an early Christmas gift, that he'd been having bursts of loose stools, and he wanted us to know, and he was taking some probiotics and some Pepto over the counter, just wanted us to know. I spoke to him. Does he have any blood in the stool? No. He's staying hydrated, so what should we do? So colitis is it's not an uncommon side effect from immunotherapy. We were putting off starting prednisone, and Dr. Hanks, what's the right thing to do if you've got a patient with bursts of loose stools who is kind of hanging in there?
So if the patient was treated with a combination regimen, which of course he was.
I'm sorry, could we have a little more microphone? Thank you.
Sorry about that. So with the patient with 68 loose stools per day, relative to baseline, we generally would start out with an oral prednisone dose. and I prefer to try to keep that dose as low as possible, whenever possible.
Okay. You know, for a few minutes, we tried to manage this with Imodium and diet. You know, prednisone or any oral steroid can suppress the immune response, and we're trying to increase it with the immunotherapy, but we saw him in clinic 2 days later, and he still had profuse diarrhea, so, and his creatinine was up to 2.44. It had been 1.23, so we admitted him to the hospital. They did a CT scan, which did show colitis or inflammation of the colon, and they gave him IV steroids because oral steroids were probably going to go whooshing out with his poop. You know, and things got better in hospital, and so they transitioned him to oral steroids. It's okay, Ms. Edmond. Transitioned him to oral steroids. So, Dr. Hanks, can you tell us a little bit about this medicine called infliximab and when it's warranted for colitis?
I think whenever we have patients that are not responding the way that we would like them to oral steroids or even IV steroids, I think that we now try to transition fairly quickly to a drug like infliximab, which is a drug that inhibits an inflammatory pathway that has traditionally been used for treating inflammatory bowel disease, for example. It turns out that this drug can also be highly effective for managing colitis secondary to immunotherapy. Oftentimes, patients after with just one dose will improve significantly over a number of hours. So this is often the preferred direction to go.
Yep. So I guess he was doing okay enough on oral steroids when he got discharged. But 9 days later, he's still having frequent loose stools, and then we did do infliximab, and with a marked improvement. So you may recall that the initial plan was to do 2 cycles of immunotherapy and go to surgery. Well, that got postponed because surgeons are not too excited to do surgery when somebody is on high-dose steroids. Dr. Dougherty, why is that, please?
It's in this case, both the steroids and the infliximab. If you're decreasing the immune response, you have a higher infection risk having surgery. So in this case, if it's not an emergent surgery and you're able to delay, it's better for a healing perspective to wait.
Okay, so surgery was scheduled for February 18th. We did rescan prior to surgery because we don't want to put somebody through a surgery when, knock on wood, there may have been disease progression elsewhere. So what do we have on the next PET scan? Myocarditis. Dr. Hanks, how often is myocarditis, which is a fancy word for inflammation of the heart, how often, if ever, is that seen with immunotherapy?
Fortunately, very infrequent.
Right. Very, very infrequently. But the PET scan said there is some uptake of the dye along the ventricle, yak, so increases the risk for cardiac abnormality. So the physician sent him off to the emergency room because we get nervous when the heart is not looking so good on a PET scan. He had a consultation with our cardiologist who has a subspecialty in oncology. And the workup, everything was very reassuring. So they do not think this was myocarditis. Okay, finally they got to surgery. And Dr. Dougherty, this was done by an ear, nose, and throat surgeon, but can you tell us a little bit about what happened here during the surgery? I know it wasn't on your watch, but.
So they did a wide local excision and a sentinel lymph node biopsy. I imagine they took 2 centimeter margins given the stage of this melanoma and the depth. The depth is usually what will determine how wide of a margin of normal tissue we take around it. So 2 centimeters is a fairly wide margin. That's the widest we would ever need to go for a melanoma. And then we inject a dye at the beginning before we take out the melanoma to find that what we call the sentinel lymph node, or that's the first 1 to usually 3 draining lymph nodes. And then we sample those and see if any cancer has spread to those lymph nodes.
So 1 lymph node was removed and it did not show any melanoma. Dr. Alrohill, it's a little difficult. Like, if there had been melanoma there, how would the report have read?
Yeah, so we can so one of the things that have evolved in what we practice is actually we're seeing treatment effect. So after a patient undergoes checkpoint inhibitor treatment or treatment targeting therapy, we can actually see the tumor dead or dying or the aftermath of death of melanocytes. So melanoma leaves a trail after it's killed. So either we see fibrosis, which is significant kind of like scar-like tissue kind of look, or we see the melanocytes dead, which is like the ghost of nuclei is basically like the death of the melanocytes, and they leave behind the melanin pigment, so we call it melanophages. If you read it in the report, that's mainly what we mean. We see the melanin pigment being deposited in the lymph node itself. So we can see if there was metastasis that got treated. In this case, this only says negative for melanoma, and there was like no signs of previous metastasis to the lymph node that responded to therapy. However, the one thing I'll mention is his excision, where we clinically saw that there was a satellite nodule from the main tumor. There was no residual satellite, so he did respond to therapy. That focus of melanoma completely regressed, and there was no residual viable disease in the excision or signs of metastasis in the sentinel lymph node.
Okay. So as far as our naked eye and technology, as far as we know, he is what we call NED, no evidence of disease, both by pathology and by scans. So Dr. Hanks, he got, per Nadina, 2 cycles of Ipi/Nivo. What would you do next?
At this point, based on the pathology report, we would just monitor him. We
Okay.
put him on a surveillance program and monitor him closely, physical exams, as well as imaging studies every couple of months.
Okay. Yep, so we're doing close surveillance, which, as Dr. Hanks says, we're going to do scans at least every 3 months. He's got to see dermatology for the rest of his life, and he'll have very thorough clinical appointments as well every 3 months. And if he remains free of disease, we will space that out over time. He is just really hoping to stay away from more medical specialists and avoid any more side effects and just enjoy the spring. Are there any questions? Yes, Ms. Mazurka.
Another question? This
Infliximab? It's also called Remicade. You may have heard of that. No?
I think I have heard of that. That's for inflammation, that's byproduct of Ipi or a dual agent, right? If you are a patient that has chronic colitis, although your treatment has been 10 years ago, but you still have the chronic colitis and all the GI issues and are full of inflammation, would that be an option to take?
So I think really having chronic colitis long-term after completing prior immunotherapy would be quite unusual, and I would be concerned about other processes that are underlying that could be contributing to those symptoms. But depending on what that is.
It all goes
Yeah.
back to.
Gotcha, I see. Well, these types of drugs that block TNF-alpha, which is an inflammatory cytokine that floats around in the bloodstream that contributes to the inflammation, can be very effective, and they can be used on a longer-term basis for certain patients.
Is it true or not true that anything ending in the MAB is a autoimmune suppressor?
That stands for monoclonal antibody?
That's not.
Yeah.
Any other questions? Mr. Cotham?
What could somebody expect to be like the time frame after they're diagnosed, they have their treatment, they have their surgery, and now they're on that, checking it every occasionally, for the side effects to actually stop and just basically the body to kind of resume its normal state? Or is that something that people deal with like consistently?
I think we've seen everything. Some of the hormonal side effects that can affect the thyroid or the adrenal gland are lifelong. But I think we've all seen patients where their GI system's just not the same, or they're just, you've heard this new normal, which is, it sounds really trite, but things can, I do think with time most people do get better and feel better, but sometimes it's just not exactly the same. Dr. Hanks?
Yeah, I think that, Fortunately, the majority of patients do reach, kind of return to their baseline and normalize, so to speak. However, there are a certain subset of patients, for example, that will develop a more of a chronic inflammatory arthritis, and that's something that they have to live with, unfortunately, for really the rest of their lives. The good news is a lot of this is can also be managed with other drugs, and I think by and large patients do quite well.
Thank you.
Sure.
Any other questions? Ms. Boykin?
Yeah, what is the highest, like, I think they said he was toxicity level 2 or 3, like, what is it?
Oh, the grading of toxicity levels?
That would be 5.
So if you had a bad reaction from autoimmune therapy
Mhm.
and colitis and toxicity level 4, would you ever revisit that kind of a treatment?
That's a great question. It really depends a lot on the circumstances surrounding that. Certainly, you have a grade 4 toxicity, we're going to be very concerned about that developing again if you're re-exposed. So in some cases, we would not want to go that direction, but it really does depend on the specifics of the circumstance.
I saw another hand. Mr. Patterson?
All thing I can say about it is pray more, worry less. There's only one person that can cure your cancer.
We do give him a little help, though. Miss Karen?
So I was on the Nandina protocol. Do you find that, and I had those symptoms and was in the hospital for 6 days, and we couldn't get the Remicade approved. I had TRICARE. Do you find that you have difficulty getting that approved?
In my personal experience, it has not been an issue, especially if you're in the hospital setting. In the inpatient setting, I think it's actually more straightforward. Outpatient setting, that could vary, and it does depend on the insurance company. But, you know, it's unfortunate. This is broadly recognized as a treatment for this particular condition.
Mr. Best?
Inflicts whatever it is it also an immunosuppressant, like prednisone?
It works in a very different way, and I think by and large, the studies that have been done have really indicated that we are not as concerned about it having a detrimental effect on the immune response generated from the immunotherapy. I think that, in my opinion, that it is actually safe to give, as opposed to what we see with steroids, where we do have data that indicates that it could be harmful and could impair responses to immunotherapy.
Any other questions? Yes, ma'am.
So does he still have colitis at all at this point?
No, that seems to be well managed. Truth be known, he's having some arthritis symptoms now, but I didn't want to put it up there. But his colitis has resolved, yes. Yes, ma'am.
And then how does someone determine whether they're doing scans at 3 months or 6 months?
Ms. Boykin said insurance.
It
Go
really
ahead.
depends on the initial staging and, you know, how exactly, what was their tumor burden and where were they at initially in terms of their disease. So if it's a higher stage, then we're going to want to survey that patient much more frequent than if it was a lower stage. So oftentimes we settle it at, you know, Q3 week imaging.
3 months.
I'm sorry, every Q3 month imaging pretty commonly. So.
And is it true that if somebody's going to recur, it tends to happen in the first 2 years after diagnosis?
Yes. So I think certainly for the majority of cases, if you're going to have a recurrence, it's going to occur within the first 2 to 3 years.
But we have seen wacky things, as some of my patients can attest to. So, yes, ma'am.
I don't know if I can say. So if patients don't get any treatment, so if you have a stage 4, kidney, I'm just making something, do you have patients that make the decision not to treat because of some of the, you know, all the side effects and things you see? And if so, what
Well, right now I have a patient with, there's a spectrum of stage 4-ness. He has a nodule in his lung, but very low tumor burden. And he's really struggling with if he wants to do treatment or not, because he's very frightened about the side effects. So we will support whatever decision he makes and do close surveillance if he chooses to do observation. I've had patients in the past for various reasons that have chosen to do no treatment. And it's hard, especially when they have what we think of as a pretty daunting disease. It's hard to watch, but we support what they do. And the pace of the disease is very individual. Some people have a slow-growing disease, and some people it's taking off quite quickly. Dr. Hanks, do you want to add anything?
I think it's important to keep in mind that this is a highly treatable disease now, relatively speaking. If you're looking, at 2010 or before, the 1-year survival was roughly 23%, and now we're looking at 80%. So things have been transformed dramatically in a relatively short period of time. So I hope that we certainly support patients in their decisions, but I hope that patients in general will recognize the fact that this is highly treatable, and that in many cases it's, in my opinion, worth moving forward treatment.
I know. Maybe one more question.
I just like to give everyone here your attitude and your thinking. If you love life like I do, you think positively every day you wake up. And I can't say it anymore. It's your attitude towards your illness. I am thankfully since 1990, and probably Dr. Frank, I haven't met you, but I have Dr. Galicia. But I am a pro-life for me, and that's what it takes, is the gumption. And UNC is my backbone, but also my Lord is my backbone. So those of you that are believers, ask Him to be with you. And those of you that aren't, think about getting Him on your side.
Okay. And on that note,
35 years, and I love life is good. I'll be 84 in
thank you, Mrs. Edmonds.
July.
She's our ambassador for the